Hello everyone, today we're going to be going over multisystem inflammatory syndrome in children, also known as MISC. While the majority of children with COVID-19 have shown very mild symptoms, some develop MISC, which may present several weeks after the child has had an active infection. MISC can even occur in children who are asymptomatic when they had COVID. There are a wide range of symptoms that can be seen with MISC. There are some mild, nonspecific symptoms such as fever, nausea, and rash, which can be assessed in a clinic or at a pediatrician's office. Others are more severe, such as trouble to breathe or chest pain, where emergency care is warranted. Clinicians should be on the lookout for signs of hypotension and shock, which could be a sign of a severe case. MISC presents very similarly to a condition known as Kawasaki disease and has many of the same complications. Both are based around inflammation with mucocutaneous features and cardiac sequelae, and both occur in children. The initial guidelines for the treatment of MISC were created based on what we know about Kawasaki disease and how it is managed. There are, however, some differences between MISC and Kawasaki disease. Kawasaki is experienced at the highest rates in Japan, while patients of African or Hispanic descent present with higher rates of MISC. While both occur in children, the exact age ranges is another area of dissimilarity. While MISC is seen in children between the ages of 3 months and 20 years old, Kawasaki is typically reserved for children under the age of 5. MISC also shows some higher rates in some of the complications, such as development of shock and more gastrointestinal and neurologic symptoms. When comparing the lab results, MISC typically presents with lower platelet counts, lower absolute lymphocyte counts, and higher CRP levels. The CDC has released guidelines to the diagnosis of MISC. There have also been diagnostic criteria released by the World Health Organization as well as some other groups. However, they all break down to pretty much the same thing. First, the patient is under 21 years old. Second, they have a fever for 24 hours. They have some history of a COVID-19 infection, whether that be current or previous. They're presenting with severe illness with 2 or more organs involved. They have laboratory evidence of inflammation, and there's no alternative diagnosis that would be able to explain what's going on with the patient. Laboratory tests are broken down into 2 tiers. The first are tests that can be completed within simple blood work, and then, if those come back suggestive of possible MISC, Tier 2 is completed to look more into the cardiac sequelae as well as some further markers for inflammation. Tier 1 consists of a CBC with differential, complete metabolic panel, ESR, CRP, and testing for SARS-CoV-2 by either PCR or serology. Tier 2 involves an echocardiogram, an electrocardiogram, troponin, B-type natriuretic peptide, BNP, as well as a proBNP, and then the inflammatory markers of D-dimer, ferritin, procalcitonin, and lactate dehydrogenase. Now we come to the treatment of MISC. The primary goal of these therapies is immunomodulation to decrease the inflammation and protect organs from damage. First line for hospitalized patients is intravenous immunoglobulin. If refractory inflammation occurs, the next step would be to initiate IV steroids or use high-dose anakinra, which works by targeted neutralization of inflammatory cytokines. In our severe patients who have been hospitalized with shock or organ-threatening disease, we start off a little more aggressively with a combination of IVIG and an IV steroid. In this case, refractory treatment would include either a higher dose of IV steroid or high-dose anakinra. In general, anakinra can be considered as an alternative in patients who cannot tolerate steroids. It is important that all of these medications are dosed using weight-based dosing, especially when considering the variety of ages we may be treating. There are patients who do not require hospitalization, and these children can remain home with the mainstay of their treatment being supportive care measures and close monitoring. There are some important considerations that must be made when initiating these therapies. First, before IVIG is initiated, cardiac function and fluid status should be assessed. If any abnormalities are found, the rate of IVIG may need to be slowed, and the treatment can be given in 2 divided doses over the course of 2 days. Diuretics can also be utilized if volume overload is a concern. Our second consideration is that hospitalized patients with MIS-C typically require a prolonged course of immunomodulatory therapy, such as steroids, and therefore slow and careful tapering should be used to prevent rebound inflammation. Anticoagulation is another step in the treatment of MIS-C that must be considered. So, who should receive anticoagulation prophylactically? All MIS-C patients should receive some level of thromboprophylaxis, with patients at high risk receiving more potent therapies. The exception, of course, being patients with an active bleed or who have a significant bleeding risk. So why do these patients require anticoagulation? Abnormalities in the coagulation cascade put the patient at an increased risk of deep vein thrombosis and pulmonary embolism. So what medication should be used for the anticoagulation? Aspirin is the first-line anticoagulant for our MIS-C patients, with the max daily dose being a low-dose aspirin, otherwise known as a baby aspirin. We are concerned with coronary artery dilation and coronary artery aneurysms, CAA. So, if the CAA Z-score is greater than 10, we will step up anticoagulation to the use of enoxaparin or warfarin. Cardiac involvement is one of the most critical complications of MIS-C. Some possible cardiac events seen in MIS-C patients include left ventricular dysfunction, coronary artery dilation, coronary artery aneurysms, arrhythmias, atrioventricular block, valvular dysfunction, and pericardial effusion. These are listed roughly in the order of prevalence, with CAAs at some level developing in about 20% of MIS-C patients. This information is with the caveat that there may be patients that have milder cases, which are less likely to have cardiac complications, who may never present to the hospital and therefore are not counted in this data. Because there are so many cardiac complications with MIS-C that can be potentially dangerous, careful monitoring is required. An electrocardiogram, EKG, should be performed every 48 hours while the patient is hospitalized, then following up in 7 to 14 days and again in 4 to 16 weeks from initial presentation. If any cardiac involvement was noted, another EKG should be completed a full year after presentation to check for any long-term damage. Cardiac magnetic resonance imaging should be completed 2 to 6 months after initial presentation in any patients who experienced moderate to severe left ventricular dysfunction. So, with all these possible complications, what can a child do to decrease the risk of developing MIS-C? The best thing to do is follow the CDC's recommendations to reduce the spread of COVID. While I'm sure you've heard all of these before, it bears repeating. You want to keep hands clean, avoid people who are sick, practice social distancing, wear face masks in public settings, avoid touching your nose, eyes, and mouth, cover your mouth with a tissue or your elbow when you sneeze or cough, clean and disinfect high-touch surfaces every day, and wash clothing and other items as needed. Also, be a good role model. These practices are not just for kids. Everyone following these steps will help stop the spread of COVID-19, as well as teaching children how to keep themselves safe. Much is still being learned about COVID-19 and MIS-C. Reporting cases not only allows the CDC to determine frequency, but also teaches us more about the condition so improvements can be made to the treatment of these children. For those of you that would like to research further into MIS-C, here are some good resources. The guidelines I presented today were both based on the American College of Rheumatology Guidelines, version 1 and version 2, which is an update that was compiled in December of 2020. The CDC provides useful up-to-date tracking of the most recent reports on MIS-C and is also where you will go to report any MIS-C cases. And the CDC, American College of Pediatrics, and Mayo Clinic are all useful resources when looking for a quick outline of the information on MIS-C, as well as a good source of information for parents or other non-healthcare parties who are looking for information without all of the medical jargon.